Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Professor Hitendra Patel, who is a global key opinion leader in robotic assisted surgery, a global key opinion leader in telesurgery, and editor-in-chief of the World Journal of Clinical Oncology. We hope you enjoy the GRASP podcast.
Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP. I'm Professor Hitendra Patel, and I'm very fortunate on today's episode to have an outstanding neurosurgeon, Dr. Nick Carleton-Bland. Good afternoon, Dr. Nick.
Hi, good afternoon. How are you?
Oh, fabulous, fabulous. Great to have you on the show. The viewers and listeners will be interested in seeing such a young man who's done so well in such a short time. So, Nick, just to start with, do you want to just tell us a little bit about how you got to being the director of neurosurgery up in Liverpool?
So I'm the director of education in neurosurgery in Liverpool, so I've been a consultant neurosurgeon for 6 years now. The Walton Centre is based in Liverpool. It's one of the largest neurosurgical centres in the UK, and we are one of the busiest, really, particularly in the auspices of spine. We've got a mixed group of something like 10 neurosurgeons with interest in spine, which is I'm one of those, and then we have 5 orthopedic spinal surgeons as well. So we're a happy mixed group of surgeons. And how I came to be here really is that I joined the Walton Centre just as sort of the first iteration of this technology came along. So navigation. And I'm sure many of your listeners will be familiar with cranial navigation, the stealth system, which has been around for 20 or so years, and that essentially maps the CT scan or the MRI scan to the patient. And the way it does that is with motion capture balls, which are attached to the patient, and a reference camera that is a bit like a motion capture camera. It's a stereoscopic infrared camera. And if it can see the balls and if it knows where the scan is, it can tell you to sub-millimeter accuracy where you are. So that's established for cranial surgery. And I was here just when we started to use this for the spine. Now, the spine's a little bit more complicated, believe it or not, because it's a mobile structure. And so I think the maths and I think that the software had to be quite a bit better to be able to kind of deal with that. And so then, as one of the biggest users of navigation in the UK, Globus, who's the company that we've gone with, approached us about the robot. So we've had the robot now for 14 months. We've done 95 robotic spinal cases, and it is much better. is the bottom line. It's actually really surprising how much I think it's improved things.
So, Nick, thank you, Nick. I know that part of your training and development of your skills was down in London in a very prestigious neurosurgical centre. So, tell me, without the robot, you've got this beautiful comparison now between having the technology and not. And then between having, as you said, navigation or image guidance. So these little iterations of improvement in technology, would you say that there was an exponential improvement in patient outcomes, or would you say it's linear?
Yeah, I wouldn't say it's exponential. And I think that with any new technology, there is definitely a learning curve. And, I think we saw, perhaps when we started to navigate, we actually saw increased operative time. And as you know, operative time probably does lead to, slightly higher risks of infection and so on. So I don't think it's exponential, but I think there is great improvements. And I think, for the individual patients, the majority of the surgery we do is MIS, so minimal access, maximal invasiveness. And I think that we were doing that with X-rays anyway. But I think what it's really allowed us to do is in spine surgery is to be able to absolutely, with great fidelity, carry out the surgical plan. And everyone no matter your training or your background, from a registrar who's in training or a very senior consultant, everyone gets the same X-rays at the end. Everyone gets the same excellent output, and that's we didn't get with navigation, believe it or not, which is a handheld device that's subject to all of the kind of risks of the tissue creeping in and pushing your hands, and the sort of toggle that you get when you're physically putting in the screws. The robot is absolutely inflexible and will not let you do that. And so I think the great democratizing step in surgery is the robot, because we all get great screw placements. And obviously screw placements is highly significant, not just acutely. We don't want to go into blood vessels, we don't want to go into nerves, but long term it really does help with pull out strength and integrity of the construct. So I think that, as you say, I've trained in a number of places in the UK, and I've done spine surgery just anatomically with what I can see in front of me, anatomically with X-ray, navigation, and now robotics. And I think that that's given me a great idea of, and a great sense of security, that I could actually go backwards a step. So if the technology were to break, I could go backwards. And I think that that's been very reassuring. That hasn't happened, but I think I've had that kind of assurance. And I guess one of the things we may be talking about is that the modern generation coming through may only learn with the robots, a bit like with general surgery. Perhaps the modern surgeons really just do lap choles, and they don't open cholecystectomies anymore. And is there an element of de-skilling? And that may be so, but I think it's too early to say at the moment. But I think that rather than being a nice kind of tactical usage, I think it's strategic. We are using the robot. I'm using the robot primarily now.
Yeah. Well, Nick, you make a good point. I mean, any technology can break down, right? Even the Ferrari that you drive, I know you drive. I'm sure that can break down. I think you're a bit psychic, because you have used my favorite word, democratizing. And we talk about democratizing in surgery. We think technology, certainly all the guests and all the people I work with, democratizing surgery around the world. We think technology is the thing that's going to allow that to happen. Now, at the moment, there is cost restriction in terms of how we can get robots to all parts of the world. But do you think there's a happy medium somewhere? What about tele-mentoring or telesurgery? Are you involved in anything like that in terms of teaching and education?
Yeah, so I'm involved with Eurospine, that is a pan-European movement that actually does a lot of education, and it is worldwide. It isn't just confined to Europe. And I think that is a great role, because I think that with surgery, there is the physical surgery, which obviously the robot is fantastic to do, but there's a lot of work up beforehand. There's patient selection, there's understanding, the changes in the understanding of the spine generally, and then there's the post-op management, and there's adjuncts, medications, psychology, and so on. So I think there is a big still a big role for tele-mentoring, MDTs, sort of a collection of different opinions. And I think that technology will only make that more accessible, Zoom calls like we're doing now, or the kind of neurosurgical websites where you can upload cases and discuss them. So I think it really will democratize, if you like, to use that word again, the planning and the understanding of the pathology. I guess despite all of that, which has existed for a while, the actual procedure, the actual implementation of the surgical plan was still variable, and it was still you as a surgeon on the day. And I think the big thing about the robot is it will make that less of a variable. But you're absolutely right, the cost is not something for every healthcare economy as things stand. But I think, just like any technology, as it becomes obvious that this is the way that surgery is going, then I believe that the costs will become more bearable. The way that we financed it at the Walton Centre is we did a 80% activity contract. So we're quite a big contract. We are, I don't want to go into finances, but we are a large contract in the UK for instrumentation. And so as part of that contract, Globus gave us this, not gave us, it was the robot was part of that contract deal. And I think standalone it is something like 750,000. So it is not a cheap piece of kit at all. But I do remember with navigation machines that they were, six-figure costs, and they have rapidly come down in price. And I think when we're able to demonstrate and when more of these surgical units are taking these, I do think the costs will come down nationally and hopefully globally.
I mean, Nick, you made a good point. I mean, we do talk about finance and grasp our system as a multiple model finance systems that you can look at to let's say cause some equanimity in terms of how you would pay for these things. But you made some amazing points there, and one of the other ones is to do with how you get the system in. I mean, how do you put a price on somebody's spinal health or their neurosurgical health when you're operating on them? If you can guarantee a better operation, I think people would pay for that, wouldn't they? It's just us in the public sector, we got to work out, cost effectiveness, don't we, as well as clinical effectiveness.
Exactly.
So tell me, I know you've been involved in a lot of educational things, and I noticed you've won some awards as well. Like, you're too humble to talk about them, I know, but I want you to tell me about them, because actually training is at the heart of the GRASP podcast, and we want everybody to be able to use this technology and apply it to their patients. Why should it just be an elite few? And so you mentioned this happy bunch of surgeons that you work with in Liverpool. And can I just say, I've been to a bar called the Philharmonic in Liverpool, so I know your part of the world really well. Not that I drink alcohol, or not too much anyway. But probably a reason why you guys are happy, is those lovely places to go to. But tell me, as part of this happy group of people, you must have had a lot of cooperation amongst all of you to make this happen. What would you say to that?
Yeah, and I think that introduction of new services within any company or the NHS generally is definitely a function of the people and the culture, and I think that we do have a culture at the Walton Centre which is really, I think, quite special. We're quite a small trust. We only do neurology and neurosurgery and neurophysiology. We don't do all the other allied surgical medical specialties, but it makes for a very can-do and quite a friendly atmosphere, I think. And so the introduction, I think we were quite open to. There was obviously, for the surgeons who'd been using navigation, it seemed like the natural progression of using navigation. But what's interesting is that surgeons who weren't previously navigating have kind of leapfrogged the first iteration and are now absolutely signed up to this second iteration, the robot, because the X-rays kind of speak for themselves, if you see what I mean. Yeah. But I think, coming back to the training, I think that it is so reliable. In my opinion, it's so reliable that actually you can be, as a consultant, a lot less hands-on, and you can actually stand back and you can train. And I think the other thing that is significant in surgery is your stress as the consultant. That it's quite a stressful thing with the placement of these pedicle screws. If they're offline, they can cause injury to the nerves, injury to the blood vessels, but also you can actually use up the bone. And if we have too many false trajectories, then that bit of bone is not useful, and we have to extend the operation. So there's quite a bit of tension in the unspoken tension. And I think the things about this is that you can be a lot more, as a trainer, you can be a lot more relaxed and let the trainees use it. I think that, going back to what I was saying previously, because the spine is not exposed, this is almost like a radiological procedure. We're watching a TV screen like a big computer game and trusting it. The trainees will really become au fait with the robotics, but perhaps wouldn't be so exposed to the traditional open techniques. And I think that there probably is a balance to be struck there. But I think educationalists like you and I probably have that responsibility to still teach open methods, or perhaps use different either models or simulation or cadaveric work to keep that skill set going. And I think that's something I've been conscious of, because I don't want a whole slew of new trainees who are dependent on the robot, because as there are so many of us, occasionally there can be scheduling clashes. So far we've managed to work around it, but in the future it could be a rate limiting factor.
So that beautifully dovetails, Nick, into the models. So do you want to just describe some of the hybrid or simulation models, or you mentioned cadaveric? What are you using in the Walton Centre to train? What can people use apart from patients, obviously?
Yeah, exactly. And I think you're absolutely right that in the old days, there'd be a textbook and then there'd be a patient and nothing between the two, which is terrifying. The general public think that a bit like aviation would have our surgeons in flight simulators for hours and hours on end, and that has not been the case up until I think these last few years. Again, the Walton Centre, we're very lucky, was supported by a number of charities. The John Fairclough charity in particular bought us a really wonderful simulator. So there's a Canadian producer of air flight simulators that have actually produced a surgical simulator for neurosurgery. And there's only one in the UK, and we have it, so we're very, very lucky. And so I still do believe in the bookwork, don't get me wrong. And the trainees all have kind of a reading list and a section of reading. But we have online resources. We use the Neurosurgical Atlas, which has lots and lots of videos. So I believe that's the next step from the reading, is the watching actively. You could watch in theatre, but I think you can watch it at home with this Neurosurgical Atlas, because there's anatomy that's labelled and there's a good voiceover. So the next step, I think, is the active skills acquisition. And so I do have some pretty, basic, if you like, models that we use, task trainers, things for like EVD placement or for laminectomies. And there are commercially available, very expensive ones that we use for the models. But I think the next is the simulator. And so this simulator is a 3D vision haptic simulator, and it can simulate something like 20 neurosurgical procedures. So the spine is in there, craniotomies are in there, tumour resections. And I think the real utility for this is for the slightly more senior registrar who is about to go and do perhaps an emergency endoscopic third ventriculostomy. They'll read about it, they watch it, they can actually simulate it, and then go into theatre. And, they've already had that cognitive plan of the different stages. They've got the kind of haptics in terms of the workflow. And I think that is going to be the future, that we're going to be simulating every operation. So we never allow surgeons to try or to learn a surgery on a patient before they've simulated it. I still think cadaveric has a role. It's expensive, and obviously some people don't really like it because they are cadavers. But I think in terms of demonstrating an entire operation in a relatively consequence-free environment, cadaveric work is fantastic. And so we are lucky that in Manchester we have a lab that we utilise. So I see it very much like that: bookwork, videos, task trainer, simple real life simulators, and then the virtual simulator, and then surgery. Yeah. And I think that probably the thing that we're trying to get, which will be the final step, is AR. And I think that, and you see these things on LinkedIn and on the internet with surgeons wearing headsets where they actually overlay the CT scan or the MRI scan. And so you're operating on a patient, but you both share that mental model. You're both seeing the anatomy, and you can even put on trajectories. And I think that that's something that we don't yet have. And a HoloLens or something is definitely on my Christmas list to really bridge that gap. And then I think we will have a real fit for purpose graded exposure.
Nick, that's a fantastic synopsis across the board, really. Just for the audience, part of what Nick has just said concerns what we call prehabilitation, and that is the before surgery practice. And there's multiple ways you can do that, and Nick's gone through all of those things. Tell me, Nick, in terms of, I might have a HoloLens lying around I could send you, but we talk about cadavers, and obviously now they have soft fix cadavers, which is why they're brilliant for this sort of practice, if you like, without potentially risking a patient. But the other thing is 3D printing. Now we have this new soft 3D printing of brains and spines and livers and kidneys and all sorts of things. And any experiences with the 3D printing up in Walton?
So I personally don't, actually. I think I've probably that's probably a bit remiss of me, because I think that many surgeons have done 3D printed models of the actual patient they're going to operate on, and the students could simulate clipping that aneurysm or putting in that DHS on the actual bones that they're going to see. And certainly there are 3D printers around in our universities, but I personally haven't yet used that. And I think that would be a really, I'm probably missing a trick there. I think I probably should be thinking about utilising that a bit more.
Well, Nick, my name isn't Father Christmas, but it is coming up to Christmas, so I'm sure that charity of yours will be happy to try and oblige. I mean, we've noticed across the sector, all surgical sectors, 3D printing is becoming a thing, a sort of central thing as part of simulation, pre-operative planning, that sort of thing. So anyway, just a little thought while I was going through this with you. So now, listen, it is coming up to Christmas, of course. So I want to just talk to you a little bit about you now, because for the audience who are not aware of Nick, he's not just the Ferrari driving neurosurgeon. He's actually a man who has got a master's in business administration, MBA. And so he's obviously interested in not just the surgery, but how we are cost effective. And that's close to my heart also. So Nick, can you just tell me what made you do the master's in business administration?
I think it was observation, and I would probably say a little bit of frustration of watching a system unfold. And I guess as you get more senior, you start to see that there really are potential improvements in the system. And I think system improvement was really where I was at. And the NHS is, I think, slightly notorious for being relatively change averse. And I think that it's all of our duties really to have an awareness of system improvement, because I think when there's a critical mass, then actually we can actually make change and be a bit more receptive to change. So I think really just through observations, I was a medical leadership fellow, and it was one of those one of my duties with that. I was actually undergoing projects, small QI projects, and it really, I got bitten by the bug, and I really thought that we can use this thinking, this system improvements, not only to improve safety, but actually to improve efficiency. And so that's what really led me to do that. And I think it was a really interesting time to do that master's. And I got to train with the graduate medical managers for the NHS. It was the same program. So actually, I think there was a bit of shared understanding. And I think that as a clinician, it's very easy to look at professional managers and think that they don't get medicine or they don't care about patients. That may be very controversial. What I learned from that experience is actually they are absolutely signed up to caring for patients. And I actually found that really quite surprising. And then I felt bad about myself for being surprised about that. But actually, these medical managers are, there with the absolute best intentions and working together, but it's an unwieldy system. And so I kind of applied that to think about how we can improve the surgery, and I guess the utilization of the robot is a huge outlay, but I do think that over the next 20 years we'll be using it, we'll see less complications, and we'll see other benefits, and some of the benefits of using the robot is that for instance, we use less X-ray, so the staff aren't hit with so much in the way of X-ray beams. That also means that the radiographer is freed up. So actually, there's kind of lots of knock-on savings if we move to this technology.
I mean, Nick, you say that, but with your master's hat on, if you compare radiotherapy linear accelerators and how many are bought in hospitals and how they're utilised, it's actually more expensive in some regards than robotic systems. So I think we haven't had an opportunity to properly compare costs of surgical new technologies versus more established technologies in the world of oncology, etc. So, any thoughts on that?
Yeah, and I think going back to what we said originally, there hasn't been an exponential drop in surgical time with these robotics. There hasn't been a massive notable change in symptoms because it was going pretty well before robotics, but I think the benefits I think will come through, and I think the rising tide raises all boats, and I think that there is a variation within surgery of accuracy, perhaps. I mean, I don't really know how to say that, and I think that is removed from this system, and so I think that we are going to be reliably and precisely delivering the same care, so everyone. Even if the surgeon's having a bad day or it's a different surgeon, it doesn't matter how great a pair of hands you are, you're going to get the same result. So I think that that we will see those benefits. But you're right. I think it's a lot of money to outlay. And if you can't have a definite reduction in length of stay or a reduction in this or a reduction in that, then it's hard, I think, to justify it. And in a way, we're lucky at the Walton Centre that we've been able to sort of trial this out. And I think there are many surgical units now watching to see, what our experiences are. And I think that we are experiencing real positivity with the robot, but also I think we're taking on cases that would just not be technically possible with any other technique. And I think
sorry, there's interesting comments you've made, because a colleague of mine was saying that the robotic technologies are lowering the postcode lottery of surgery, so you can more reliably get similar outcomes across the board. So anyway, let's move on then. So we talked a lot about your life and work in robotics and technology and democratizing surgery and all those wonderful things that you've said. But a lot of the audience want to know about you as an individual. So when you're not operating and running the hospital and running the finances, etc., what do you do?
Oh, right. Outside of that, well, I've got I think I've got a reasonable work life balance, and I think it is really important to do that, because the stresses and strains of the job, as you know, can be quite wearing. I mean, I suppose my real focus is my children, my family, my lovely wife, and my three kids, who are all very much into netball, and so I'm primarily a taxi driving service for my children, which actually I find incredibly fulfilling and rewarding, living vicariously through my children's successes. But I outside of that, I don't do too many other dangerous activities, really. I'm a bit more of a reading, watching films kind of guy. But it's a good point. I think that it's easy to get sucked into just doing work, and thinking about work all the time. I think it's really important to have that life outside of it, because that's the sustaining part.
Wow, thank you. See, people who actually want to know this. How do you survive being a surgeon? Particularly in the public sector like we're in. But listen, Nick Carleton-Bland, this will be an absolute pleasure to hear about neurosurgery, how you deliver it, how you train people in it, and also talking about the things around it. So this is the Global Robotics Assisted Surgery podcast. Thank you for listening.
Thank you for listening to the Global Robotic Assisted Surgery podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.